Hello to everyone. It is well known that dry eye is a common fatal disease. Therefore, the treatment must be tailored according to the different presentation and pathophysiology of the disease, as well as according to the main causative factor. Despite medical therapy still represented the current mainstay of the treatment, a variety of device-assisted techniques have been recently proposed. Among them, that puts the light to represent the option for treatment of rosacea and evaporative dry eye, organ to Meibomian dysfunction. EPL emits non-coherent polychromatic light at the wavelength length in the range between 500 and 1000 nanometer. Different mechanisms of action of the setting of dry eye has been suggested, such as blood vessel thrombosis, Meibomian heating and liquefaction, increase of inflammatory molecules, suppression of metalloproteinases, demolates eradication, and also photobiomodulation. Two major meta-analyses have been published recently on the effects of EPL in the setting of dry eye. The first was published in 2020 and included 114 patients collected by 3 randomized trials. The second one was published on GRAPH in 2021 and included 539 patients collected from 9 randomized trials. The main results provided by these two meta-analyses said that EPL combined with Meibomian expression may be an effective and safe treatment to improve tear-film stability in patients with Meibomian gland dysfunction. However, to date, there is no sufficient evidence to confirm an improvement in the dry eye symptoms. Therefore, it is not recommended to perform EPL as the only therapy for dry eye. In fact, the positive effects of EPL may decrease over time within 6 months from the last session, suggesting the need to repeat the procedure for several times, better if in combination with other treatment options. However, due to the limited quantity and quality of randomized clinical trials, larger when designed, blinded anti-center trials are still needed to provide more robust evidence about this therapy. More recently, low-level light therapy was introduced as a new option for evaporative dry eye due to Meibomian gland dysfunction. This technique is able to produce analgesic and anti-inflammatory effects. It is based on a more chromatic light with different wavelengths. About the mechanism of action, near-infrared light is on the light absorber, and the reduced cell co-activation determines change in the expression of its protein. Photobiomodulation increases the availability of electrons to corpse, resulting in enhanced cellular metabolism and upregulation of ATP and CAMP. But is it possible to combine EPL and LLLT to obtain end-well stimulation? And if so, which are the results of these procedures performed simultaneously? The first clinical trial, published in Cornea in 2021, evaluated 94 eyes of 47 patients with dry eye on Meibomian gland dysfunction. These patients were treated with a light. 3 months after treatment, positive results have been obtained in these patients. Furthermore, clinical and molecular factors change supported the improvement in patient symptomatology and the reduced inflammation. In particular, OSD score significantly decreased in more than 90% of eyes, as well as tear breakup time significantly increased in more than 70% of eyes. Furthermore, Meibomian unexpressibility score significantly increased in more than 80% of eyes. A significant reduction in tear fluid levels of the male pro-inflammatory cytokines was also demonstrated in this study. The second clinical trial was published in Journal of Ophthalmology in in 2021 and evaluated the 40 eyes of 20 patients suffering from silver and serum dry eye. These patients were treated with red eye. All patients, except for one, completed an experimental study without the need for reintegrating tear cells. 1 and 3 months after treatment, tear film stability and ocular discomfort symptoms improved. About tear production, Schiller values increased after treatment, but without statistical significance. The third clinical study was published in Clinical Ophthalmologist in 2019, and this study evaluated prospectively 230 patients treated with light in 3 different centers. Well, patients that enrolled in this study had been treated in the past without success with conventional medical therapy. After treatment, ocular discomfort symptoms, Meibomian gland dysfunction grade, and breakup time significantly improved. Although a synergy between LLLT and EPL is well documented, is it possible to use with success low-level light therapy as the only therapy for dry eye disease? To investigate this issue, we performed a randomized clinical trial comparing the efficacy of low-level light therapy versus intense-exposure light infested with dry eye disease owing to Meibomian gland dysfunction. These results have been recently published according to and are available on the journal website. The study was conducted in the University Hospital of Catanzaro between September 2020 and June 2021. Patients were randomized to receive 4 sessions once weekly of LLLT or EPL. Both patients and investigators were linked to application. During the study period, the patients were instructed to instill appreciability status 4 times a day. Non-invasive ocular surface support cap was performed by means of a cardiograph before and 2 weeks after the last session of treatment. For the measurement of non-invasive per capita, tear meniscus A, retina score, Meibomian score, and Meibomian gland loss. Dry eye symptoms were evaluated by means of speed score. Overall, 40 patients were enrolled. Half of them were randomized to receive LLLT, while the others received EPL. There were no significant differences for all demographic and clinical parameters at baseline between patient of the two groups. About ocular discomfort symptoms, despite the speed score improved in both groups after treatment, the improvement was significantly greater in the LLLT group compared to the EPL. About tear production, tear meniscus 8 significantly increased after treatment in the LLLT group, but not in the EPL group. Conversely, the values of non-invasive breakout time, retina score, Meibomian score, and Meibomian loss, the upper and lower eyelids, did not change significantly after treatment. As stated before, tear meniscus 8 significantly increased in the LLLT group, but not in the EPL group, while it is well known that EPL alone has little effect on tear production. Conversely, tissue photobiomodulation induced by LLLT could be able to affect the function of the retinal gland, thus improving its secretion. So in conclusion, it is recognized that EPL and LLLT are both non-invasive, well-tolerated treatments that reduce dry eye and symptoms when used in combination. In our recent randomized clinical trial on the EPL versus LLLT, the other procedure was shown to be more effective for the treatment of dry eye, allowing a significantly greater reduction of ocular discomfort symptoms and a higher improvement of tear production. Therefore, LLLT can be used with success for dry eye treatment both alone and in combination with EPL. Thanks for your attention. For more information, please write to giuseppe.giannaccare@gmail.com for receiving feedback or more information about our works. I'll add. Thanks.